Let's dive right into this. Imagine you've got a patient in your clinic. They're looking pretty unwell, maybe they've got a bit of a fever going on. But then you reach out to check their pulse at the wrist, and there's absolutely nothing. No pulse at all. Welcome to this high-yield medical explainer on a truly fascinating and honestly quite dangerous condition known as Takayasu arteritis. You'll often hear it dramatically referred to as the pulseless disease, and for good reason.
So here's our clinical roadmap for today. We'll start off with exactly what this pulseless disease is, cover the epidemiology, unpack those tricky clinical manifestations, look at how we actually image and diagnose it, and finally, wrap things up with treatment and prognosis. All right, let's get right into it.
Section 1. The pulseless disease.
To really grasp the clinical signs you're going to see at the bedside, we absolutely have to start with the fundamental pathophysiology. Basically, Takayasu arteritis is a granulomatous inflammation of the aorta and its major branches. Think of it like a domino effect. This granulomatous process directly causes the walls of these massive, critical blood vessels to thicken up. And obviously, when those walls thicken, the lumen, the actual space where the blood needs to flow, gets dangerously narrow. We're talking severe stenosis here. This physical restriction of blood flow is literally what sets the stage for every single downstream vascular symptom we're going to look at, including that infamous absent pulse we just talked about.
Moving right along to Section 2, Epidemiology and Demographics.
Recognizing the typical patient profile is honestly half the battle when it comes to catching this disease early. As you can see from this massive discrepancy here, Takayasu arteritis overwhelmingly affects women. We are talking about a striking 8-to-1 ratio of female to male incidence. So if you're ever presented with a confusing case involving severe vascular compromise, the statistical odds heavily favor the patient being female.
And to add to that, the peak incidence hits right between 25 and 30 years of age. This is primarily a disease of young adults, which frankly makes the presence of such severe vascular disease all the more alarming. It just doesn't fit the usual picture of vascular wear and tear, right? Oh, and heritage plays a huge role too. The data shows it most commonly affects individuals of Asian descent. So young females of Asian heritage, that's the primary demographic you really need to lock into your brain for this pathology.
Section 3. Clinical manifestations.
Okay, so we know who generally gets it, but how does it actually show up? Well, the really tricky thing about Takayasu arteritis is that the early symptoms are just incredibly nonspecific. We're talking your standard generic inflammatory red flags: fever, malaise, maybe some joint pain, night sweats. It can so easily masquerade as a run-of-the-mill infection or just some other random autoimmune issue. Plus, patients might present with skin manifestations, things like erythema nodosum, which are those tender red bumps you usually find on the shins, or urticaria, basically hives. At this early stage, that classic pulseless sign, it might not even be fully apparent yet, which makes this a massive diagnostic puzzle.
Now, because the aorta and its major branches literally supply the entire body, the downstream effects of that stenosis we talked about earlier are incredibly wide-ranging. Just look at this graphic. If blood flow up to the head is compromised, you're looking at headaches, vision loss, syncope, or even a stroke. If the coronary arteries get involved, well, that leads straight to angina pectoris or a myocardial infarction. Look down at the renal arteries. Stenosis there is going to trigger severe hypertension. And of course, looking at the limbs, you'll see intermittent claudication, numbness, and yep, there's our hallmark sign, decreased bilateral brachial and radial pulses. It's essentially a systemic vascular crisis, all originating from that one primary area of aortic inflammation.
Which brings us to Section 4. Imaging and Diagnosis.
Given how wildly complex and varied the presentation can be across all those different organ systems, we need some really definitive tools to lock in our diagnosis. It all starts with building the clinical picture. The young female patient, the missing pulse, and maybe some vascular bruits, that distinct whooshing sound of turbulent blood flow. Next up, labs. They're often going to show a really non-specific inflammatory state, elevated ESR, elevated CRP, and you might see some leukocytosis, a high white blood cell count, along with anemia. And hey, taking serial measurements of these is actually a fantastic tool for monitoring the patient later on. But labs alone just aren't enough. The diagnosis might start clinical, but you absolutely have to confirm it with imaging or a biopsy.
Check this out. Here we have a real-life angiogram of the thoracic aorta in a patient with Takayasu arteritis. Let's break this image down together. You can clearly see the stenoses, that dramatic pinched narrowing right where those white arrows are pointing in the great vessels branching off the top. We're looking at the innominate, the left common carotid, and the left subclavian arteries. See how incredibly restricted they look? And then, if you look over at the green overlay, you'll notice the ascending aorta is actually dilated. That's a direct consequence of the disease process pushing back. This visual evidence right here, this mix of stenosis and dilation, that is your definitive smoking gun.
Now, while textbook guidelines might casually say get imaging or a biopsy, the clinical reality on the ground is entirely different. Diagnostic confirmation frequently relies on imaging, simply because the affected vessels are often completely inaccessible. I mean, you can't just casually or safely biopsy the aortic arch. There's no way. So that makes advanced imaging modalities the absolute, undeniable heroes of this whole diagnostic maze.
And that reality totally dictates our specific imaging strategy. MR angiography, or MRA, is absolutely the preferred initial study for all these patients. Why? Because it is just fantastic at spotting that crucial wall thickening and the contrast enhancement that screams, hey, there's active, ongoing inflammation right here. Alternatively, you can use CT angiography or even standard angiography. Oh, and echocardiology is highly, highly recommended for all patients too. You've got to assess for secondary complications like aortic regurgitation or ventricular hypertrophy that pops up thanks to that severe hypertension.
Section 5. Treatment and prognosis.
So, once we've caught the disease and confidently confirmed it with our MRI, how do we actually go about saving our patient's vital vessels? Well, because this is such a severe, fiery, inflammatory disease, the treatment really has to be swift and aggressive. We manage Takayasu arteritis primarily with high-dose glucocorticoids, usually combined with other heavy-hitting immunosuppressants. If you think about it, this approach is actually quite similar to how we'd manage something like ANCA-associated vasculitis. The primary, overarching goal is to quickly and effectively shut down that granulomatous inflammation before the vessel stenosis leads to permanent, irreversible tissue ischemia, or worse, a catastrophic vascular event.
And you know what? The outcome of that aggressive medical treatment is actually incredibly inspiring. When this disease is caught early enough and successfully treated, the 5-year survival rate sits at a really strong 83%. So yes, it's a wildly serious disease, for sure, but with a high level of clinical suspicion, precise imaging, and rapid immunosuppressive therapy, the prognosis is actually overwhelmingly optimistic.
All right, so here's your key takeaway for today. Whenever you see a young female patient presenting with unexplained systemic inflammation, crazy hypertension, and notably absent or unequal pulses, your brain needs to immediately jump to Takayasu arteritis, the pulseless disease. You catch it early with an MRA and you treat it hard with steroids. But, going through all of this really does leave you wondering, what exactly triggers the human body to suddenly wage such a destructive war on its own largest, most critical pipeline in the first place? It's a pretty humbling reminder of just how much we still have left to learn about these mysterious autoimmune triggers. Anyway, thank you so much for joining me for this explainer. If you found this visual breakdown helpful and you want to keep crushing your clinical reviews, please make sure to hit that subscribe button for the Mid-Medicine channel right now. We've got plenty more high-yield, visually driven explainers coming your way to keep you right at the top of your game. Until next time, keep learning and stay curious.